Ever since I started medical school in 2019, I always heard these are unprecedented times. And boy, would I love to not live in unprecedented times. But here we are. When I started medical school at Harvard Medical School, I walked in there and I knew that I was going to be different because I looked different. I walked around in hoops like the ones that I'm wearing now. And as a Black woman in a space that typically was not inviting to Black women, I knew that it was going to be important that I brought the struggles of my community and their experiences into that space. So naturally in 2020, when George Floyd was murdered, along with Breonna Taylor and Ahmaud Arbery, I went to Twitter to talk about some of the ways that those murders were reflective of some of the experiences happening in my own community. But what's interesting is that as I did that advocacy, I always had this question in the back of my mind. Did my advocacy make me a professional? Or did that make me unprofessional? As I wrote papers in lay press in the New England Journal of Medicine, talking about the ways that racism was manifesting in medical education and in our day-to-day experiences, I wondered, does this make me a professional? So as I grappled with that as an individual, I started to think about it even more about what it means for our profession when I started to have more fellowship experiences, like those led by the incredible David Goldman. I had the opportunity to be a FASB scholar. And as we walked around Auschwitz and had conversations about the way that the medical institution was complicit in allowing those atrocities to happen, it made me reflect on the ways that we're starting to see more heinous atrocities happening at the global scale even today. So I think that this conversation is not really about this abstract idea of what is professionalism, but it's about how do we make sure that we move forward with those ideals in praxis when our profession is being challenged and asking that question about what is our role and how do we make sure that we advocate for those who are most underserved. And what that's helped me understand about all of this is that at one point or another, every revolutionary act was once considered unprofessional. That goes when we think about the person who decided that they were not going to sit at the back of the bus, the person who decided to call out their attending because they were using race when they calculated the EGFR equation, and that person who decided to stand up and say, no, I think that we should not be talking about that undocumented patient in this way. So as we move forward with this conversation, I want to just pose 3 questions for us to consider throughout the rest of our panel. The first is, who does professionalism serve? The second is, if it is meant to serve our communities and patients, then how do we transform those values into praxis? And the third is, how do we grapple with the dynamic definition of professionalism in an increasingly inequitable world?
I'm going to take this in a different direction a little bit and talk about some of the structural factors that are shaping the way we practice. And I would say one contrast or maybe one theme is we kind of implicitly ignore the environment. We ignore the macro environment. We're learning a lot about the political environment these days, but all these factors, as I'll talk about, have been shaping the delivery of healthcare, access to healthcare for a really long time. You know, so for a long time we've seen headlines like this about mergers of this hospital and that hospital, this health system and that health system, and we've seen a huge wave of change in the United States over our careers. And I want to go back and do a little bit of history. So in Bill Clinton's first term, remember healthcare reform was what he ran on. And Alan Enthoven was an economist at Stanford, had this great idea that Kaiser was working so well in California. What if we scaled Kaiser at a national level? And he had this idea of managed competition. And managed competition was that physicians and health plans would work together to keep patients out of hospitals. Hospitals were expensive, still are expensive, and we could reduce the cost of healthcare if we keep people out of hospitals. And so that was the thrust of Clinton healthcare reform. Obviously, that died in Congress very quickly, but hospitals got the message. And so what we've seen is this dramatic shift in the delivery of healthcare over 20, 30 years, where almost every market in the US is very highly concentrated with a very limited number of healthcare systems. And that's in response that health systems learned that they were vulnerable to doctors working with health plans, and so they had to beef up in order to have negotiating leverage with especially commercial health plans. And then our friend Elliot Fisher had an idea about 15 years ago. I'm sure Elliot hates that I keep bringing this up, but he had an idea that actually changed the rhetoric, that doctors and hospitals would work together to reduce the cost of healthcare. And he kind of ignored at that time what had been happening on the ground in terms of the delivery system and the consolidation and the impact on prices. And so now all of a sudden, we were going to have this combined entity of doctors and health systems rather than doctors and health plans. And the result was this amazing shift in employment over the last decade and a half, where 6% of docs work for hospitals directly in 2012, and now 52% do. I mean, that's just an amazing shift in terms of how we work. And then we have the rise of other organizations, such as private equity. And so we've gone from being a profession where we ran our own practices to being employees. And employees, to be an employee in a large organization, a multi-billion-dollar organization, requires an entirely different set of skills that we don't teach. We don't teach. I still am shocked when I do my rounds and talk about the difference between Medicare and Medicaid to our med students. Yes. So they don't teach it at Hopkins either. So Alan's idea about Kaiser is kind of interesting. It's actually fun to go back and learn the history of Kaiser and how Kaiser came about. But here's the structure of Kaiser, which is there's a health plan, there are hospitals, and there are medical groups called Permanente medical groups. And the interesting thing about the Kaiser structure is the hospitals are not a profit center, they're a cost center. So in Kaiser, having someone in the hospital is a negative. I would never pick on Stanford, I pick on Duke all the time because I came. So at Duke, having a patient in the hospital is a positive, it's a win. So it's a very different structure, but and Kaiser's not perfect, as anyone who works for Kaiser will tell you. But once a year, there's an arm wrestling between the hospitals and the health plans, and everyone has to get together and share governance. And I love this illustration. I think this is from Becker's Hospital Review of health system governance structure. So we're all working in these very large health systems, the integrated delivery systems, and this is from 2017 or 2018. And this is their ideas of the optimal organizational structures for these large integrated health systems. And if you can see it from the back of the room, what's really fascinating is there is no role for us. We're not part of the optimal governance structure at all. And so I think that's the shift, and that's what we're all seeing day to day on the ground in our practices. We're no different than any other service of employed people at the hospital. And so the question is, how do we respond to that? What's dramatically different is being an employee and all of a sudden having no stake or control in the overall organizational structure. And so we got looking at this, looking at the question of unions. Where did unions come from? How would unions maybe change this dynamic of employed physicians in these large integrated systems? And one of the things we realized very quickly was the foundational legal structure of unions is very old, almost a century old, but really has to do with Ford Motor Workers on the assembly line as the basic premise. And we've written several times about this, about unions as a governance question rather than unions as a wage question. Almost all the time when you see physicians advocating for union or unionizations, it has a lot to do, publicly at least, with access to care, staffing of services, the way, very patient-oriented issues. There may be or may not be wage issues associated with it, but generally it's about how do we take care of the patients that we're working with. And our hospital leaders are financial stewards of the healthcare system. But obviously what we're talking about today is, well, as physicians, we have other ideas and other functions, and maybe having another 2% on the margin compared to having another primary care clinic is an appropriate trade-off. One of the challenges with the idea of unions as a response to these organizational structures is the question of bargaining unit. And so to form a union, you have to decide who your colleagues are. In joining a union, there's lots of different ways this has happened. You can have single hospitals, physicians joining a union, single organizations, hospitals at one health system. You can have single specialty anesthesiologists at Cedars-Sinai in LA formed a union. You can have mixed models that would be all primary care providers, whether physicians or non-physicians. But what this brings up is that having a union means that you could have lots of different unions. Obviously, nursing's been very effective in terms of some of the governance issues that they're grappling with through unionization, but they all form generally are one group. If we're trying to think about resource allocation between our destination service lines and our non-destination service lines, we have to, the union doesn't reconcile that if the service line people are in one union and non-service line people, destination service line people are in another union. So, if we can't find a way to reconcile the physician interests in the governance structure, then union won't solve that for us. And then we looked outside. There are lots of different union models that are really interesting to think about. Here's a couple of union members that you might know about. And actually, here's their contract, which has a lot to do with amenities that they get, which is really interesting. But it also has a lot to do with how they treat the rookies. So we've looked at unions in terms of professional sports, which are probably the most analogous to medicine, but also airline pilots. And in the longer version of this talk, the Southwest airline pilots were the ones 2 years ago that actually raised the issue of the infrastructure to schedule their flights had been falling behind and been underinvested. So I think there's lots of interesting ways in which unions could be interesting to help us at least think through some of the challenges that we're facing at a systemic level. As physicians, what do we want from health systems as an employer? I will say I'm acting chief of hospital medicine, and one of the things we're doing, we've created something called hospital medicine labs, which basically asks, what were they asking us to do? What is our job during the day? Why are we doing that? Did I have to go to medical school to do that? None of us had to type in medical school in my days. In fact, they took the computer away when we went to med school. What do we want from our health systems employer? How do we get leverage to negotiate that? And can we come together as a single voice or a limited set of voices to negotiate with management really explicitly to advocate for ourselves and for our patients? And then here's, the axiom to this: we can't bargain collectively if we're not a collective with shared purpose. So thank you very much, and thanks for inviting me.
My story about advocacy, community, and personal accountability begins with the story of Hilda. This is a patient who became a very dear friend and completely changed the trajectory of my career. Hilda left Mexico when she was a child, escaping poverty and domestic violence. I met her when she was in her 20s. She had 2 small boys, and she had just been diagnosed with kidney failure. Because she was undocumented, she only had access to dialysis once a week, basically every 7 days when she was on the brink of death. She'd come to the hospital short of breath, nauseous, hyperkalemic, and what she most worried about were her boys. Her boys stayed in the hospital with her, they weren't going to school, and part of this was because they had weekly death anxiety. They didn't know if their mom would survive to the following week. In 2013, Hilda had a cardiac arrest at home. Her boys called an ambulance, they witnessed her receive CPR, and it was after that she made a very difficult decision. She decided to find adoptive parents for her boys, and she stopped emergency dialysis, and she died on Mother's Day in 2014. After Hilda passed away, it was very hard. Before she passed away, I actually connected with several large and small dialysis organizations, as well as legislators in the governor's office. And I couldn't convince anyone to dialyze her, and I didn't understand the policies to change them. I knew that I couldn't continue to provide this type of care, and I felt compelled to lean in and change this. I read everything possible on this and came across one article written by a health executive who worked for CMS, and in it he described how one of the necessary next steps was to conduct research to demonstrate why this needs to change. And at the time, I'd been a full-time clinician for about 6 years, had zero research experience, and intentionally worked at the safety net hospital because research was not required. But I decided in that moment to start applying for grants and essentially to learn to conduct research for the sole purpose of changing policy. And so as I describe our team's successful policy change, I am going to describe 6 strategies that were key in changing this in our state. The first was connecting with our patients and caregivers. They became my partners in all of this work, in the research, the advocacy. They created a WhatsApp group where we all communicated with media, with some of our decision makers. They also created a nonprofit group called Club de Ñones Latinos, where they organized themselves and started connecting with people across the country in other states. And as our research grew and our community work grew, we grew our coalition and started including decision makers and other people. So this group of incredible people was honestly the force that pushed this work forward. The next key strategy was conducting advocacy-informed research. We connected with lots of allies and people who disagreed to inform some of our most important and moving research questions. The first publications were qualitative. The very first one was qualitative interviews with undocumented immigrants receiving emergency dialysis. And they basically described significant physical and psychosocial distress from having to wait for their symptoms to accumulate every 7 days. They also described weekly death anxiety and risking death to meet eligibility criteria, because many of them would consume foods very high in potassium just outside the hospital door so that their potassium would be high enough, knowing that it could push them into cardiac arrest. We also interviewed caregivers and then another study interviewing clinicians. Clinicians described several drivers of burnout, including needless suffering and high mortality. And this was especially true in our ED providers who saw patients coming in unable to speak in full sentences because they were full of pulmonary edema. And then by the time they were dialyzed, they were discharged and able to participate in life. We also published several quantitative studies, one demonstrating worse mortality, another one worse quality of life, and then worse symptom burden. And I just want to mention that compared to the quantitative studies, the qualitative studies actually drew in more attention from media and policy stakeholders because they were the patient narratives that people could truly understand. The next key strategy was developing effective communication. And we were very intentional about engaging with people who disagreed with us so that we could understand their values and perspectives and really use that to frame a lot of our messaging. We worked really hard to build relationships with media in the state and trusting relationships. We need them as an ally, especially in public advocacy. And what we did for them is we gathered stories. Patients were willing to be interviewed at the risk of deportation. We wrote press releases. We basically created a roadmap for how they could cover this. And it increased our reach far beyond Colorado, which was truly incredible because then we started conducting multi-site studies and other things. The fourth key strategy was understanding policy and the process to change this. This was critically important so that we could be very strategic about the relationships that we needed to build and influence decision makers. Many of you are familiar with EMTALA, or the Emergency Medical Treatment and Active Labor Act. That's the language you see on this slide. But basically, hospitals are required to screen, stabilize, and treat patients found to have an emergency. And many states abide by this exact language. But what is critically important, and what we learned from our policy analysis, is that CMS defers to states to define the qualifying conditions and services. This means that a state could include kidney failure and provide dialysis and other services. And so CMS, again, defers to states, and this is how many states had modified their policy for this patient population. And so in conducting advocacy-informed research, disseminating this information through effective communication, and being very strategic about the policy change, we connected with several decision makers. Patients came with us, and on February 1st, 2019, Colorado expanded benefits for undocumented immigrants, including standard dialysis, and then a few months later, also peritoneal dialysis. And this is one of my favorite pictures because this shows the solidarity amongst patients. They have their hand that has their AV fistula in the middle. So just, incredible partnership with the patients. The fifth and critically important strategy was to conduct research post-implementation of the policy, because it's critically important to document the outcomes as well as to do cost analyses. And so on the right, you see a study. It's a pre-post intervention study. I looked at quality of life, symptom burden, and also conducted interviews before patients transitioned from emergency and then after they transitioned to standard dialysis. And patients experienced, of course, an improvement in quality of life, a reduction in symptom burden, and also felt humanized and were able to start working again. And on the other side, it's an economic analysis using our state Medicaid data. Prior to the policy change, the cost was $20,000 per person per month, and it was reduced to $5,500 per person per month. In this slide, I show the dissemination of the work. One publication was co-authored with our state Medicaid director, which was incredible because then she and I both went on to mentor other states to make a similar policy change. In the middle, I collaborated with the National Kidney Foundation and ASN to write a letter addressing state Medicaid directors, urging them to do the same, and several professional societies signed on, including SGIM and SHM and many others. And lastly is an ASN website. They actually created a committee that meets twice a month sometimes, but essentially they sort of put everything on one website because they realized that it was kind of a burden to connect with physicians across the country each time someone was interested, and so they put everything in this one website, and they have a team that provides support. So in 2019, there were about 15 states that provided statewide dialysis. We looked at this again in 22, and there are now over 20 states, and we're actively working with several more states right now, despite the current administration. Since this initial work, our team has led several policy changes, some sub-regulatory, bill development. We have worked as a team with our patients and caregivers and many in the state on many policy changes, and also conducted research. So the team of patients that I showed you initially, they've actually been part of my community steering committee for the past entire decade, and have informed many of our clinical trials. And in this moment, we're seeing our policies rescinded, paused, budget removed. My grants have been canceled. But I just want to share that I am choosing to fight. I'm working with the state very closely. I'm very involved on boards. I'm helping them with strategy. How do we, despite these changes, continue to provide care for this patient population and do so in a way that keeps them safe?
Good morning, everybody. Happy to talk to you today about an intervention we did at LA General to try to empower staff to do the right thing. The best thing about this intervention is that we got a manuscript published in JAMA Internal Network with a Lord of the Rings title that is all about Dungeons and Dragons. That's by far the best thing about this intervention. And you're like, well, why are you talking about Dungeons and Dragons? What does that have to do with hospitals? I know there's some closeted Dungeons and Dragons players out there, but I'm gonna explain it so you can pretend you don't know. So I'm gonna go through it. It's all good, okay? When you play D&D, you create a character, and you have to decide what kind of personality they're gonna have. You decide, are they gonna be good, neutral, or evil? And that's pretty self-explanatory. But you also have to decide if they're gonna be lawful, neutral, or chaotic. What do we mean by that? So lawful characters in D&D believe that all deviations from the rules are wrong, period, with no exceptions. In a hospital, think about your regulatory affairs people. Think about your counsel. To be honest, most managers in hospitals are lawful. Then there's the opposite alignment, chaotic. Chaotic characters in D&D think rules are wrong, period, and there should be no rules, and I should be able to do whatever feels right. Think about some of your maverick surgeons. I know you've seen this, right? And then there's the neutral alignment, living in the middle. We need rules. We have to have rules, but no rule is perfect. Life is strange, and sometimes things that are unexpected happen, and it's okay to deviate from the rules in those circumstances. So I'm going to tell you 3 patient stories that inspired this journey. Think to yourself during these stories, are you lawful, neutral, or chaotic? And the reason I'm telling you these 3 stories, yes, they happen locally, but this kind of stuff happens at hospitals all over the United States every day. True story number 1. Patient in the ICU gets better, gets downgraded to a ward bed. The downgrade orders are in, but there is no open ward bed. So the patient is going to board in the ICU for several hours. And during that time, it turned out he needed a PRN medication, and nursing refused to accept any orders for said medication. And I got a call in my office yelling at me from the hospitalist that nursing wasn't taking the orders. Me getting a call yelling at me is going to be a common theme to all 3 of these stories, okay? My office is the nexus of unhappiness in the universe. All unhappy thoughts pass through it. So I called the nurse manager, and I said, why aren't you taking the orders? And she said, we have a unit structured standard. This is a nursing policy. The patient has been downgraded. This is no longer an ICU patient. The ICU docs can't write the order. And yet the hospitalists are not privileged to practice in a licensed ICU bed, so they can't write the order either, so we can't accept any orders. And I was like, are you really serious about this right now? I gotta solve this for you. Go ahead and override your policy. True story number 1. True story number 2. 55-year-old with a lower GI bleed. It is not a rapid bleed. He is not dying. He does not need an emergent procedure. But he needs a diagnostic colonoscopy, not a screening, a diagnostic colonoscopy, and it needs to be done in the next 1 or 2 weeks. He has some comorbidities. It's going to need to be with anesthesia. So the nurse says, who's going to pick you up after the procedure with anesthesia? He says, I live alone. I don't have any family. I don't feel comfortable asking friends to pick me up. I'm just going to Uber home. And she says, unfortunately, hospital policy requires that we know who's going to pick you up for safety reasons, so I cannot schedule your colonoscopy. Now, this patient is an EMT. He has worked as an EMT for 25 years before he retired. He knows how hospitals work. So guess what he does? He calls the CMO to yell at him. And I'm like, all right, I guess I got to fix this one too. True story number 3, I am not making this up. This really happened. 18-year-old kid downtown gets violently mugged. Very violent. Paramedics take him to our trauma center. Orthopedics evaluates him. He has an open fracture. They put a temporary pin in. He is in traction. They say, you don't need an emergency surgery. You're not going to go today, but you need a scheduled operation in the next 2 to 3 days, or there's a risk the leg will not heal properly. They call the surgery scheduler down to the ED. Surgery scheduler comes down. Okay, I need to see your ID badge. Your photo ID so I can schedule your surgery. The kid says, I don't have my ID. My wallet was stolen during the mugging. Oh, that's too bad. Unfortunately, hospital policy requires that I see a photo ID to schedule a surgery. He stops, he's thinking, problem solving. Oh, light bulb. Okay, I got it. Go on down to the DMV. Get yourself a new license and come on back and I'll schedule your surgery. I am not making this up. This actually happened. Okay? So the patient freaked out. The nurses freaked out. They called the orthopedic surgeons. And y'all know what the orthopedic surgeons did, right? Yeah. They called and yelled at me. I'm like, I didn't do this. Why are you yelling at me? I'll take care of it, no worries. I figured out who the scheduler was. I called the scheduler. So listen, man, don't worry about it. It's all good. Go ahead and schedule the surgery. Override the policy. And I'm thinking he's going to say, okay, thanks, man. I knew the right thing to do, but I didn't want to get in trouble. This is a policy violation. That is not what I heard. Instead, what I heard with a tone of righteous indignation. So I'm just supposed to ignore hospital policy when I want? And I was like, well, yeah, when the decision otherwise would be stupid. And this is when I realized we had a real problem, because you see, our staff had become so beaten down by policies that they had developed Stockholm syndrome and had begun to sympathize with the policies rather than the patients. And this was the origin of the policy to override policies, which was developed with risk management and counsel input and created a due process mechanism to allow us to deal with these situations. The policy says that any staff member can override any policy when all of the below conditions are true. First, the staff member has a, quote, reasonable belief that the override is needed to benefit a patient or a staff member. And it defines a reasonable belief as one that is likely to be agreed upon by other similarly qualified people in similar circumstances. This is the first basis of due process. If somebody later objects, this is the evidence standard that is going to be judged to decide if this was a reasonable decision. The override has to be within the normal scope and expertise of the staff member. So pharmacists can't override nursing policies and doctors can't override pharmacy policies, for example. The staff member's supervisor is called and has to agree. So now you see you have two people. It's not just one D&D chaotic person going around doing whatever they want. Two people have a shared reasonable belief, and this is the second leg of the due process mechanism in the policy. The override gets documented, including the rationale for why. The manager of the area is notified so they can consider, should we revise this policy to prevent this from happening again? When the policy went live, it was used 5 or 6 times in the first couple of months, frankly with great fanfare. People were super excited about this. And then it stopped being used. It hasn't been used in quite a while. And so we're talking to our staff, why aren't you using this anymore? And they're like, we don't need to. We're just doing the right thing up front. Ironically, activating the policy gave the message to the staff that we had their back, and they no longer felt they needed to fall back on stupid policies anymore. Now, this brings up an important point, because a common thing I heard before the policy went live was, can you really trust your frontline staff to make these decisions? Shouldn't you be making these decisions? And I've actually heard this from several people across the US since the manuscript was published. And to that I respond, do you hear the words coming out of your mouth right now? Are you listening to yourself? We hired these people. We trained these people. If we can't trust them to make these decisions, we are incompetent at hiring and training. That's on us, not on them. So when y'all are talking about how you want to empower your staff, is that a platitude or are you serious? Because if you're serious, it's time to put your money where your mouth is. Okay? So, bottom line, I admit it. I'm a D&D nerd. Not only am I a D&D nerd, I'm a neutral good D&D nerd. Does anybody else out there want to join me?
In one way or another, y'all have been causing good trouble. And really the point of our discussion today is thinking about this evolving definition of professionalism. And I'm curious to know if at any point in your advocacy, were you considered unprofessional, and how might your efforts be reflective of an evolving definition of professionalism in healthcare broadly? And that's for everybody.
I'll jump in. Good trouble, yes. I was nearly fired a couple of times when I initially started working on this. You know, it's interesting because as I started learning more about this and understanding how to change this across the country, what's clear is that in some states, this actually brings in revenue, and so it's not something people want to talk about very often because emergency Medicaid, it's a lot of money. But as far as professionalism and what's happened since then, I mean, it's been incredible. One of the pictures that I showed earlier was a picture with our state Medicaid director and the chief financial officer of Denver Health. She's the one that stood up front and center and said, we may be making money from this, but we have to do right by our patients. And when this changed in Colorado, she actually stood up in front of the board and said, I am not going to lose a minute of sleep because this change is like saying we're going to stop waterboarding. And so it completely changed the narrative about what it means to do the right thing and cause trouble.
Absolutely. I think that part of professionalism can include challenging the system. I think the key is finding constructive ways to challenge the system. And I did get some pushback initially, but this is why you sit down with your team and you bring in the right people, in this case, risk and legal. We weren't going to be able to do this if the lawyers were like, this isn't going to work. We had to find a way to so we created this due process mechanism. So you find a way to make the system realize, to your point, that it's better off with this than it was before.
You know, I think we're at a really interesting juncture. You know, you've said since 2019 it's been, you know, a really challenging time. I hate to go back to when Don Berwick first told me it was a challenging time. So, you know, I think things are very different now, and where we are structurally, where we are professionally is very different. And my concern is we're incredibly ill-equipped for that. We're ill-equipped to understand the economics, we're ill-equipped to understand the policy, and then I'm at Stanford, so it's all about how AI is going to work and work with us, hopefully not replace us too soon. But these are like really massive changes, and we're a profession that changes very slowly. And we also focus, we define professionalism really narrowly. I mean, I think we just heard this amazing story where you've opened up the definition of what professionalism was. You could have just stayed in taking care of the patient the best you could with all these rules around you that make no sense, and you didn't accept that. We have rules around us that make no sense in terms of how we pay for health care, how we administer, you know, drug benefits, prior authorization. These are really kind of massive structural things. We have 318,000 different health plans in the U.S. market, and each has their own set of rules. Like who would, you know, that's like an incredible Faustian dilemma, and that's at the macro level. And so where is it that we're working to kind of explain to each other what the challenges are, debate that, and then bring that forward with 1, 2, 3 different propositions. And in fact, at a time like this where it really is important to have a coherent voice in response, you know, the fact that we don't have a place where those arguments are happening weekly is a real deficit for, you know, our ability to be effective for our patients.
Absolutely. And Kevin, you asked a very simple question earlier, which was, you know, can we come together? And I remember, you know, shout out to all the incredible residents that helped organize us to help us get a contract with MGB. We recently became unionized. But I do remember that initially it was a challenge to try to get people to buy into the idea of a union because there were a lot of challenges with this tension of professionalism. Is it professional for me as a physician to be a part of a union? Will this impact my career prospects? Because now it might be seen that if I'm a part of this union, I might not be the type of person that they will want to become division chief in the future. So could you maybe speak to that tension of unionization and professionalism?
You know, again, that goes to the conservatism of our profession. You know, and Brad's a proud union member. We've been on a panel before. But, you know, none of us were parts of unions because physicians didn't work for hospitals. Except for a couple of, you know, except for the public sector and in a couple of cases, you know, this idea about unionization was not part of the norm. And so none of us know anything about it, and so we're scared of it, and so we reject it, you know. Like the first time, there was a great story at Duke about using beta blockers in heart failure patients. And Chris O'Connor was going to get fired if he ever did that until he did a clinical trial to show that that was the right thing to do. So I think this initial response, I don't know that unionization is the perfect response. But I do know it's a response to governance challenges, and if we're not going to do unionization as a solution, we have to come up with some other solution. There has to be a real structural solution. We can't be employees at will and advocate for our patients, and as soon as you advocate and get somebody angry, you get at risk of being fired. You know, that's the alternative.
Yeah.
And with budget transitions that we're all going to face in the next couple of months, you know, who knows how the systems are going to go? You know, do you really need primary care? You know, do I really need to have someplace to discharge my patient to when they're yelling at me for length of stay? You know, but we make money off orthopedic surgery and outpatient oncology. Why can't we just do that? Like every consulting company in the country is telling every one of your health systems exactly that. Mm-hmm. You know, plus minus one or two other things. So, you know, how are we going to respond to those challenges? And how are we going to respond when they say, no, you got to see more patients, no, we've got to cap length of stay, whatever the other, you know, no, you can't work with a PA, you know, whatever the change is going to be in response to the budget cuts, you're not going to see a change that says we're going to reduce the number of administrators that we have by X percent. You're going to say you physicians have to work harder.
Absolutely. Thank you for that. Lily, I want to pop over to you because first off, I just want to acknowledge the fact that you essentially pioneered an entire area of research and engaging with policy, and that is incredible. And second, I just want to acknowledge the heaviness of this moment. I also just want to acknowledge the heaviness of this moment, and for you to be able to come in here and talk about the stories that you're sharing. I can only imagine how difficult that is, and we thank you for being here and being that truth to power. I think what I would like to hear more about is how you approach this idea of advocacy as a competency of being a healer and being a professional, because a lot of the skills that you learned, you really had to go out and find that education. And I think that there are some people who today would say, well, that's not the role of the physician. That's not the role of the healer. They should be focused on the bare bones medicine. So can you speak to that experience of finding that knowledge and how that might have transformed how you think about the full skill sets that a physician and a healer should have?
Yeah, thank you. No, that's a great question. You know, I think in our profession, I know we've been talking about professionalism quite a bit, but I think our duty is really to the patient in front of us. And so I feel like we engage in advocacy on a daily basis when we're practicing clinically. How much more you engage in advocacy, of course, depends on time. And, you know, Dr. Goldman yesterday said something that really hit me. He said, if you're not engaging, then you're complicit. And I think during this time when there are so many marginalized patients, how can we not engage in advocacy? And how does that inform how we consider professionalism, the values and attributes of professionalism? Do we engage in collective advocacy? How, you know, could this country continue for even an hour without the physician workforce? And at what point do we put our foot down and actually work together to protect marginalized patients? And so as I think about advocacy and the skill sets, it's not something that we learn traditionally. I think, you know, for me, when I describe my work, it seems very linear, but truly there were so many twists and turns. Lots of tears, lots of moments of feeling completely broken. And what I take away from my experience is that I leaned on the expertise of many. My patients, the caregivers, the nonprofit community-based organizations that were willing to do policy analyses, the health system, our CFO, who was willing to do an economic analysis. So lots of different people that shaped my advocacy skills. And one of the second to last slides that I showed was actually a hand drawing of a framework that I developed with one of my mentors, Russell Glasgow. He developed REAIM, but we started thinking about a framework for physicians and scientists who want to engage in advocacy-informed research. So this is engaging in research for the purpose of changing policy. And and so that's something I do now. We talked a lot about hope yesterday. 36% of people, I think age 25 to 35, value advocacy work. And so with this framework that we've developed and what I've learned, I try to teach as much as I can across the country whenever I'm invited so that people can gain some of these skills, but I absolutely think that it should be part of our training.
Yes, I agree. Okay, Brad, it's rare that I get a CMO in front of me to get to ask them all the questions.
Don't yell at me.
I won't yell at you.
Thank you.
But I think that what you were able to accomplish is so rare in that it was a collaboration between administrator and clinicians and the workforce of the hospital. And I'm curious to learn more about why you think that this particular initiative was successful, given that it's not usual that you see these collaborations happen in a way that is meaningful and successful.
It's a great question, Lash. I mean, it's amazing to me no one's done this before because it's so popular now at our hospital. Like they're thrilled. I think part of it is that I'm very annoying. So I was like, I don't care what you guys normally do. This is stupid. Let's do something that makes sense. But I think it was also because we were able to find the middle ground where people were concerned. What about the experience and expertise of the frontline staff? What about the legal ramifications? Are you going to get sued? Okay, well, let's create a mechanism, a process. We created a policy that allowed an override of policy. And that just got everybody on board. It was just finding that middle ground to get everybody on board.
Right. They were just like, of course this makes sense. And that's all it took. Awesome. So I think my next question is around moral injury. And I think that moral injury has kind of really become a big topic of conversation recently. And in some ways, similar to professionalism, I think if you ask any one person, they'll have a different way of defining moral injury because of how it might manifest in their own work, whether they're a primary care doctor or it might be someone who works more in an administrative role. But in all of your work, it's kind of like your bright spots have found some kind of way to potentially combat moral injury. And I would love to hear about how in your work, in this redefining professionalism, how that can also be a way to prevent and fight against moral injury.
So our team has conducted 3 qualitative studies interviewing clinicians who work in safety net hospitals to better understand the drivers of burnout. Mm-hmm. And it's really interesting because consistently what we keep hearing is that moral injury, there's a lot of reasons for moral injury, but one is sort of being compelled to provide care and that you think and that is suboptimal and goes against your ethics. And Jess talked yesterday about FIGGI, fear, ignorance, greed, and inertia. And I think, so much of that leads to moral injury. And yesterday also Lisa talked about friction and how being in an environment of friction helps you react and helps you identify your own agency. And so, I don't know, in considering all those things, I think it's interesting how, this is truly a mechanism to reduce moral injury when we advocate for the person in front of us, when we lean in and learn about some of these unjust policies that are coming down so that we can be part of strategically changing them.
There's a scene in the movie Airplane 2. It's an old movie, but I'm old, where he's trying to land the space shuttle on the moon, and the tower's yelling at him to keep the shuttle up, and he's like, I'm trying, but she's fighting me, and a boxing glove from the shuttle is punching him in the face while he's trying to land the shuttle. That's moral injury. When you're fighting against the system that you're supposed to be working for to take care of patients, and the system is punching you in the face metaphorically, that's moral injury. And when you can find a way to get the system to not fight against its employees, whether that's unionization, creating a collectivism, or changing the way that the work is done so that we're all in alignment. The staff, the administration, the payers, we're all in alignment to do the right thing. That's going to alleviate a lot of moral injury.
I think, people ask me, I'm at Stanford now, this is my 8th year, but what happened when I moved from the East Coast to the West Coast and what the difference was. And the West, Stanford, kind of two things. One is the West Coast is a lot about optimism, has a lot to do with sunny days. But there is like an energy to tackle big problems. And so part of that is to actually have the courage to try and think that these things are addressable. That's the 99% of it. But the other thing is really, Stanford does, there's a lot of innovation theory at Stanford. And innovation theory always starts with needs finding first, a problem. What is the problem? How do we carefully define the problem? And if we spend enough time trying to define the problem, you can actually build solutions. And so there's a discipline to this that's actually really empowering. So when people come forward, and have an issue, we have lots of ways to now tackle that. So it's not that these things are any longer unsolvable problems. Now it's a big uphill climb. There's no success that's guaranteed, but at least there's a pathway. You can be working on things. So, all of these cases where we take one, here's a problem, and then how do I get to, if I define that problem carefully, can I build evidence around it? Can I build a solution? That's the innovation model that's out here, which is incredibly empowering. So it's, I think that's the optimism of a way of getting out of it.
Yeah. And I think you bring up an important point about how within medicine, there's like a lot of microcultures. So I think that there's some folks who might work in different departments or different areas of the hospital where they might feel moral injury in a different way, or they might interface with social justice in a different way. So with all that being said, with so much diversity in our lived experiences as healers, how do we think about how the work that you all have done, how do we make that a part of the dominant culture of medicine? And is that possible?
Well, I think that's what we're trying to do today. Mm-hmm. I've stayed in academics my entire career, and part of it is, again, we're not educated for this. Mm. Go back and look at your curriculum. At Duke they actually gave me 2 days with the med students to introduce them to the healthcare system, and that was like twice. They would only do that for like 2 or 3 years, but we had a remarkable meeting about a decade ago, looking at the second Obama administration, ideas about how health services research could inform what might happen. And what was amazing was the conversation amongst the people in the room where there was no consensus or understanding about the markets and the dynamics of the market. Yeah. And people had lots of opinions, but things that are not regression based are really hard to publish. And these big issues that we're dealing with, we're doing a lot of work right now on administrative costs. So, if we could solve all the problems in the world, the biggest one is how we manage the healthcare system in the U.S. So, and Don's talked eloquently about this. We spend more money to manage the healthcare system in the United States than France, Germany, and Italy combined spend on healthcare, and they all have 100%, universal healthcare access. Mm-hmm. And so, can we tackle that? I think we have to get smart, and we have to get consensus as a field, and there are very few ways of that happening, which is a really unfortunate circumstance, because the people on the other side, there's like 3 different think tanks you can go to, and they're going to tell you what the answer is. Yeah. None of us like the answer, maybe, I'm assuming, But the other side has a very clear answer.
We may not learn about any of that stuff, but at least we all learn about the Krebs cycle. So there's that.
Yeah.
Yes, key learnings, indeed.
Did the Krebs cycle come up in your work?
I don't recall it coming up, but yeah.
It set the basis for the framework that you made, right?
There you go. It's somewhere in there.
Yes. So one other question that I have is, speaking of unprecedented times, I think that unfortunately we find ourselves again in unprecedented times. We have an ongoing starvation, question of ethnic cleansing in Gaza. We have the ongoing conversations about the protections of migrants and their access to Medicaid. We have active attacks on DEI, research within our institutions, and a federal government that feels like they're actively attacking our institutions. And what we stand for is trying to provide care to our patients. Lilia, you spoke a little bit about how powerful it was to have different organizations, professional institutions within medicine to sign on to the work that you were doing. I think that right now what's been a challenge is that there seems like there's so much going on and there's no way of leveling where we all stand on so many different issues that I think that some professional organizations have decided not to say anything. And I think that sometimes that silence can be deafening for our patients and communities. So in thinking about bright spots in advocacy, as things get more complex and we think about professionalism in our role, how are y'all thinking about navigating these things as leaders, and what responsibility the medical institution might have in responding to these ongoing challenges?
I'll say that when you are part of the administrative structure of an organization, you do have to be very careful because you're not speaking about, when you're speaking publicly, you're not speaking about your own personal opinions. You could be perceived as representing the organization, and you have to be really careful. So I think advocacy needs to be done in a very constructive manner because sometimes it can backfire if it's done in a manner that the people you're trying to convince are really upset about. So I'll speak in generalities, not about anything, any person in particular, but for example, not being a psychiatrist, I said this last night, if you're dealing with a malignant narcissist, publicly making fun of them may not actually get you what you want. Now that's just a random example, not specific to anything. So you have to be careful about how you do the advocacy.
I'll say for me personally, during these times, I am honestly, everything that's coming down from the federal government, I'm reading in excruciating detail because I want to understand strategically, like, how are we going to document the adverse outcomes related to some of these new policies that are coming down? How are we going to inform, certain boards? So for example, I sit on on the state-appointed board that thinks about access to care for undocumented immigrants. So I am, I need to understand all of those policies so that I can strategically help the state think about how our state is going to respond and how we're going to keep people safe. So for me, it has meant leaning in, understanding the policies in detail, and being extremely strategic about who I'm connecting with and how I'm bringing people together to the table so that we can respond in a way that's safe for our patients. And then separate from that, I am presenting a lot because I really, in my heart, need to have hope. And hope is something that we talked a lot about yesterday. How are we going to inspire and motivate the next generation of physician researchers or physicians overall that want to do this work? And so my hope is, to sort of teach them how to do this, but also show them how I've done this during, a time when it was also contentious in 2019. And so that's my way of responding. And then, thinking about ways to engage in collective advocacy. How can I help people find their own agency as clinicians so that they can lean into some of this friction?
Yeah, we're not prepared for this, in any way, shape, or form. But we're not used to, like, my editorials when to the major medical journals are not going to get picked up by anybody on TikTok, and so all the norms of our profession about how we've worked for our entire careers to be successful have just gone out the window, because what we need are stories. What we need to start with are stories. The quantitative research and the regressions won't help us. By the time we get a regression to show how harmful these policies were, 5 years from now, when you get through 2 years of NIH grant cycles, it's going to be way too late. So I think, that we have to understand that we're in a time where we have to do things differently, and I think we also have to think about, and we're working on this right now, we're doing a study of language. Like, what language do we use? There's language that we could use that's going to turn off half the country, right? We've figured that out. So what language, at least the preliminary work we do, everyone's excited about the work everyone's doing. But they're not excited about our language, which is an easy thing we might be able to fix. So I do think stories and social media, I don't know how many hands went up on social media and tweets and stuff like that. I don't tweet at all. But if we're going to win the war, it's going to be through social media. And we're not even there.
I mean, this is about influence. Again, language I'd be careful with, win the war. We need to find ways to connect to people. And people have diverse opinions. And just because somebody has a different opinion than us doesn't mean they're evil. They just have a different view, and we have to figure out a way. We collectively have a unified message that is communicated in a way that does not alienate half the country, or you're going to lose the battle, right? You're going to not succeed in the change you're trying to get across.
Thank you. That was just fabulous. I'm Susan Winkler, and I run a foundation that supports the Food and Drug Administration, connecting it to the outside world. So yeah, it's a little weird in this room. But you are the outside world that we try to connect into a regulator. My question, Dr. Cervantes, is for you. I'm thinking about, I love the structure of how to change policy. How do we then approach when it's responding to not policy, but the power of the podium, where it's really about statements and declarations and trying to eliminate, like I'm thinking about the changing of, it's not LGBTQ anymore, it's just LGB, because there aren't any T's and Q's according to the power of the podium. Would you change your structure to try and respond to the power of the podium, or can we use that advocacy structure to respond to podium challenges that aren't yet policy challenges?
That is a tough question that I may need to digest a bit, but I think a quick response, I really love what Dr. Schulman said about narratives and how oftentimes the narratives are what is most powerful, honestly, and reaches more people on all sides, truly. Right now, our team is engaging in several qualitative studies, and I'll provide an example. One of the qualitative studies we're conducting is interviewing undocumented immigrants who have preemptively decided to be organ donors. So on their US driver's license, they have a heart. Because oftentimes the narrative of this patient population is that they come to our country, they take jobs, there's all this, and so these qualitative interviews are beautiful because it really demonstrates that they are here to participate and contribute. And so it's just an example of sort of a narrative that we're putting out there. But I think communication is critically important. You have to, create effective communication by understanding the values and perspectives of people whose opinions differ. And I continued to use the framework only because I realized that to continue to create change, we have to change ourselves. We have to change how we message. We have to change the types of studies that we do. We have to iteratively move with what's happening at the federal level.
Thank you. It's terrific, Jay Bott, Cook County Health and Deloitte. One thing that I am concerned about is in this moment, in this time, self-censorship and the impact it has on our moral injury as well as the health of our patients and community. And so as I think about advocacy and how we evolve what that means in this environment and for the future, I think the point of our narrative is important in stories. How do we help our physician community move towards action in that, and when they're feeling like they can't? And I think story from communities is part of it. And so I think about misinformation and disinformation and how advocacy can help try to address that. But I think we got to think about it differently, now and into the future.
Is that a question? Or?
Yeah.
You can respond to it. But I think about, narrative is one aspect, but there may be other ways to think about advocacy. And so I don't know if there's other examples or approaches that you think about outside of traditional methods, and using some of the technologies and tools that may be emerging as new ways to identify information, the insights, the song underneath the words, what's really being said, to then be able to use some of these tools for our own benefit to advocate for these issues. That's one, but the statement was a concern about self-censorship and how it impacts us, and how we try to override that, but also how it impacts the trajectory of our patients. If I look 5 years from now, this moment has an impact on the health of our patients.
Mm-hmm.
Yes.
Hi, I'm Marianne Green. I'm the Dean for Education at Northwestern. This question is largely for you, Kevin. You use the word "we" a lot and how important it is for us to have a collective space for action and better governance. How unified do you think the physician "we" is in your experience and travels around? How likely is that we can unify?
So, one of the things that's up for debate right now is the role of the RUC in terms of assigning compensation models. So when you read Bill Shaw's original paper, the RVRVS system was a way primary care physicians were going to be compensated and not specialists. So we're not a big we, but part of that is I don't know. Along the way, we choose a specialty, and then you're in that tribe. And I think this is a time where you have to come together. Like the radiologists aren't going to get paid if there's no money coming into the system. And so I think we, again, if this is a zero-sum game and we're all going to fight each other, like as a Hunger Games, across subspecialties, that's not going to get us very far. And so if we see the current time as a collective threat, that all of these things are under threat, I think that's going to be much, there's a chance of it working. But we're not a we, we're very splintered.
Ready? So I'm another Marianne Udow-Phillips from the University of Michigan School of Public Health and on the Board of Michigan Medicine. And my question for you is somewhat building off that, but it's the role of organized medicine and your views of the role of organized medicine. You talked about unionization, and yet when we, for example, saw the Kennedy nomination, I believe the only organized group that opposed the Kennedy nomination was the American Public Health Association. The AMA was notably silent. And yet we see the impact of having someone who purveys false information has on medicine. What's your view about the role of organized medicine in standing up in these times and speaking up, and how physicians can influence standing up?
You know, to be cynical, organized medicine's been around compensation. You know, and it's how can we advocate for ourselves to get more RVUs? And look, my job as chief of hospital medicine, I want more RVUs too. But I think this is a time where we're going to have to go back to the drawing board. And none of us are going to get RVUs if, you know, things keep going. So, you know, organized medicine's was silent, was active, I think, during Clinton's healthcare reform, was really silent during Obamacare. There wasn't, you know, a huge amount of things except for the compensation things. We've been silent for a decade. You know, the governance structures is again up to us. But if we don't have a vehicle to come together either about misinformation or about core values of healthcare and the harm that potentially is being done, like we've been very passive about these massive changes over the last decade and a half. The fact that we went to from physicians, 20 years ago to employees as an entire community and didn't say a word, that's really speaks volumes. So it's a good time to rethink some of the basic structures, the role of these organizations, why they exist, and it's also a really scary time. So you have Harvard kind of taking one direction and Columbia taking a very different direction in terms of navigating these things. And it's hard for people in traditional leadership structures to figure out which response is correct. So but I do think we're being challenged in a way we've never been challenged to this point. And then it's not just today, it's like going forward. So, we've been talking a lot about Medicaid, but look at Medicare. Yeah, and Medicare, both the funding for Medicare is running a $452 billion deficit this year, but it's also what's happening to our kids. So if you borrow money to pay for roads and bridges, that's fine because they could use the roads and bridges. If you borrow money to pay for total joint replacement for 70 million people who are retired, your kids are going to pay for that for the rest of their lives, and they're going to get no benefit out of it. So there's also that concept going forward. Structurally, we're out of kilter in terms of where healthcare is going.
Mm-hmm. Really important insights, yeah.
I was just going to add, I think what I've seen is, well, my experience these last couple of years has been of hope, honestly, because I feel like I've seen a lot of professional societies not just focus on compensation within their policy groups, but really begin to think about patients and socially marginalized populations. And I give the example of ASN because this is a professional society that normally works just at the federal level. Yet they decided that access to kidney replacement for undocumented immigrants was important enough that they created a committee, a website, and signed off on this letter addressing state Medicaid directors. And when we connected with many of these professional societies, many said, we normally only work at the federal level. This isn't the kind of letter that we would sign, but they signed it, and we had several professional societies. I think that this is a room full of, very powerful people. Many of you sit on councils. Many of you have high-level roles in your professional societies. This could be a room where collective action begins to happen because of who's in here.
Any other insights, Brad? Okay. Thank you all so much for your incredible insights, for all the thoughtful questions from all the forum participants. And as we end, I just have two things that I want to share. The first is a quote by an incredible sociologist, Ruha Benjamin, out of Princeton. And she talks about how we respond to challenging times such as these. And she says that in the end, if inequity and injustice are woven into the very fabric of society, then each twist, coil, and code offers a chance for us to weave new patterns, practices, and politics. New blueprints. The vastness of the problems we face will be their undoing when we accept that we are pattern makers. whether in seemingly simple exchanges or more elaborate forms of community organizing and world building. This is a micro vision of change. So I hope that as we go on to have more conversations and we think about how we find bright spots in this very dark moment, that we remember that we are pattern makers. And the second thing I just want to do is shout out my mom. She's in the back. She is, yes. I've gotten to grow with this group of people ever since I was in medical school, and my mom raised me as a single parent. I wouldn't be here if I didn't have her as my example. She's doing incredible work with activism around autism, and I just encourage you all to chat with her. And just thank you so much for allowing us to have this conversation with you, and we hope that you have a good break. Thank you.